Hi everyone, welcome back to another episode of Behind the Science. I'm here with Rishi Shah, who co-led 5 of the JACC data reports that are in this week's issue of JACC. So Rishi, great to have you on and great to have this conversation.
Yep, thanks, Adith, and thanks for having me on.
So I guess I'll just start by asking you, what do you think are the high-level takeaways from these reports that you led?
Yeah, I think when I look back and look at all these reports sort of together, I think I see a sort of dominant theme of consistency and persistence. So starting with sort of insurance coverage, we saw modest gains between 2019 and 2024 for insurance coverage. Uninsurance fell to about 9% in 2024, and we saw really meaningful declines in the Hispanic population and the American Indian and Alaska Native population. And coverage is really foundational for health access. I think that's really important. But beyond coverage, a lot of the other measures were largely unchanged. We saw that cost-related medication non-adherence was still about 12% in 2024, especially for adults that are at or below the federal poverty level, it was about 16%. And for those that were 500% or above the poverty level, it was about 6%. And so that socioeconomic gradient still hasn't narrowed. And delaying or foregoing care due to costs also followed a very similar pattern. And we're seeing really similar things for health behaviors too. In 2024, about 62% of adults with ASCVD met neither the aerobic or strengthening exercise guidelines that were put forth by the Department of Health and Human Services back in 2018. And more than 40% of adults overall met neither of those exercise guidelines. And Black adults, 42% of Black adults had sleep less than 7 hours a day, and about 35% of those that were living below the federal poverty line experienced similar outcomes. Whereas those that were 500% and above the federal poverty level were only about 27% reported sleeping less than 7 hours in a day. And so these differences, especially in sleep and exercise, are very large and very consistent across our study period. Something that I do want to note is that telehealth rose sharply during the pandemic, but I was a little disappointed that it started to decrease steadily after 2021. But still, even in 2024, about 1 in 4 adults report having had a visit via video or phone in the past year. And 15% of adults reported no interaction with a health professional in the past year, and that number, unfortunately, has not meaningfully changed over time. So I think looking at these reports together, we're really not seeing something that's, we're not seeing health equity deteriorating a lot in this country, but it's not really converging. We're not seeing disparities collapse. We're not seeing any sort of long-lasting improvements. So we're seeing modest gains in insurance coverage, but these disparities across access, affordability, sleep, and exercise are sort of durable. And so I think what these series of reports really does add, though, is accountability. So I think we're really understanding where we are in terms of all of these outcomes. And I think, coming from backgrounds of outcomes researchers, and you know this as well, in order to really see any sort of improvements or chart the path forward, we really need to understand what the current state is like. So I'm hoping that these reports will be one of those steps in illuminating the sort of condition that we're in.
So you made a number of really great points there, Rishi, and I think, just to split it into 2 thematic segments for these reports, I think one is affordability, access, and utilization, and the others are exercise and sleep. And something that sticks out to me on the affordability, access, and utilization is across all these different strata that you're reporting, by and large, these trends are mostly stable across the 2019 and 2024 period that you guys looked at, save insurance rates and telehealth utilization that had that pandemic spike and then that return, back down a bit. So I think maybe I can stop there and just ask you, when we measure cost-related medication non-adherence and other measures of affordability and access, what other data points do you think are relevant to collect here and to study, right, to get a better sense of the income gradient, or maybe even to try to, ideally, perturb these things and make sure that, most folks, regardless of their income, can achieve adherence to their medication regimens and things like that?
It's a really great question, Adith. And I think what you mentioned was really true. The income gradient remains the most consistent and powerful pattern across every domain that we studied. And whether you're looking at medication non-adherence, delaying care, short sleep, physical inactivity, or uninsurance, you see that lower income is associated with worse outcomes. I particularly want to point out that point that you made about exercise. In 2024, 60% of adults below the poverty threshold met neither exercise guideline, compared with 37% of those that were at or above the 500% of the poverty level met those guidelines. And I think we often frame these behaviors as sort of individual choices. And so we encourage people to exercise more, sleep more, adhere to their medications. And I think those are really important public health strategies. But I think behavior sort of exists within this hierarchy of needs. And I reference there was a psychologist, Abraham Maslow, who devised this sort of hierarchy, social hierarchy of needs that individuals have. And so I think a lot about that when I look at this and how we frame modifiable risk, quote unquote, modifiable risk factors. And so somebody has like unstable housing, they don't have access to nutrient dense food, employment is precarious, or transportation is unreliable, then exercise and sleep aren't really immediate priorities for individuals. And so in that sense, I think these health behaviors are partly downstream of these social conditions. And I think what's really worthwhile to do is I'm a really big believer in community-based public health infrastructure. So I think community-based policies that are making transportation to and from appointments easier, that are providing food. Food as medicine is a great initiative as an example of that. That are really filling these social needs before addressing these sort of broader health needs. I think are really important and are a great avenue to sort of, I think, curb these gaps and start to see increases in access, affordability, and utilization of care for Americans that with lower income.
And I think that's a great point, and I want to double click on something that you said, which was that 60% of people at or below the federal poverty limit met neither aerobic or strength criteria, which is 3 in every 5 people. That's the majority. But even at 500% of the federal poverty limit, meaning these folks are making 5 times what would be considered the limit of poverty, 37% of them met neither aerobic or strength, right? So even if so we can think on one hand, as you were saying, about bringing that less than 100% federal poverty limit group at 60% to 37%, right? And that would go from every 3 in 5 not meeting to maybe 1 in 3 not meeting, which would be a huge gain. But I think the question that I am also interested in is, even when income, quote unquote, is not a problem, right? 1 in 3 are meeting neither criteria. And I wonder if you have just thoughts on that at large. I think some things that come to mind are, is it that the cost of living is just so high and that there are all these hidden expenses that maybe factor into it, right? Like, buying a car, servicing rent, all these different things, debt, and all these things that aren't captured in a static metric of 500% of the federal poverty limit. Or maybe it's other things, access to gyms or motivation or getting the right regimen. Or I guess I'm just wondering what you think of that 37% number, even amongst the highest income.
That's a really great point, Adith, and I completely agree. And I always imagine that if you're at the sort of upper echelons of American society and you're making very high amounts of money and you're wealthy, there really shouldn't be any barrier to you to have access to good healthcare and to utilize that healthcare. And so I think those points that you raised are really important. And I think it really does center back to sort of the lifestyle that we have in this country and sort of motivational factors as well. I think sedentary lifestyles, consumption of overprocessed, ultra-processed foods, I think that just becomes so mainstream in our society and our culture that even when you remove income as a barrier to health, we still are seeing really astronomically high rates of individuals that are not meeting exercise and strengthening guidelines. And I think targeting that will require more public health campaigns that are centered around behavioral improvements. And I always like talking about, there's this layer to this that I find very fascinating. And I remember when I was growing up in 2000, there was this article in the British Medical Journal that basically tried to quantify how much life expectancy would be lost for every cigarette a person smoked, for example. And they found back then in 2000 that for every cigarette that a person smokes, they're shaving 11 minutes off their life expectancy. And I remember in high school, we were sort of taught this in health class as a way to discourage individuals from smoking and adopting these sort of negative behaviors. I think they redid the estimates now closer to about 20 minutes that you're losing. But the point I'm trying to make there is that I think these sort of statistics lodge in the minds of the public, and because they're very vivid. And so I think about how can we translate these sort of abstract risks into these sort of tangible human scale units that change how people think. And so something that I'm really interested in doing is how can we generate sort of these analogous statistics for other risk behaviors like inactivity and sleep and medication non-adherence in ways that are really scientifically rigorous, but also viscerally communicable. And I think that will really help change public perception about these things, and also hopefully encourage positive health behaviors.
Yeah, I hadn't heard the 20 minutes thing, but as you're saying that, I think, exercise, take a statin, get enough, sleep, quote unquote, and these different things that we may ask patients to do is stuff that it's a risk to be had in the future at some point, 20 years down the line, 30 years down the line, which may or may not happen, right? I mean, just because you sleep 5, I mean, I think that is the thing that is, hard for me and for everyone to sort of wrap their head around, right? Versus you have an infection and you get antibiotics and you watch the infection go down, or you watch you can breathe better. And I think that point that you made around better communication to people about the risks is a really, really nice point. And I wonder what sort of analyses, presentations, stats we can bring, right? I think maybe that's something that we can bring to the table, that we can communicate with patients when you're in the clinic, or even just public health messaging. So I really like that suggestion. And I guess just to pivot gears a little bit, Rishi, across these analyses, largely the NHIS data set was being used. And I guess we don't often focus on stats here, and in this segment, opting to be more clinically relevant. But I just wonder if you'd share a little bit about the trade-offs and the considerations and the methodology behind these data reports.
Sure. So like you mentioned, all of our analyses rely on the National Health Interview Survey and across these 5 reports, which is an in-person household survey conducted annually since 1957. And so the NHIS annually will sample the civilian population of the United States and will collect detailed information about their health status, behaviors, access, utilization, and affordability of healthcare. I think it remains to this day one of the most important surveillance systems in our country, and is really a great barometer for the state of health in our country. The NHIS uses something called a complex sampling design. So groups are basically, so the US is split into these sampling units and different strata, and within which are basically communities and neighborhoods. And the NHIS will then sample these neighborhoods to create a nationally representative sample of the US. What that means is that each year there are about 30,000 adults that are involved in the NHIS, that participate in the NHIS. They're assigned a survey weight. And so what that means is when we analyze the data, each person's survey weight is basically a number that indicates how representative or how many people in the US population does this one person represent. So the idea is when you sum all of these sampling weights together, you'll arrive at the census estimation for the US adult population. And so what's really valuable there is that the NHIS is nationally representative, and so where the data and statistics that we're generating are applicable to the entire US population rather than just the individuals that were interviewed in the sample that we have. To sort of estimate the annual rates and compare groups, we sort of have sort of 2 main ways that we sort of talked about doing this. We chose the route of using multivariable logistic regression. And in simple terms, regression sort of allows us to estimate the probability of an outcome while accounting for other variables or covariates of interest like age, sex, region, income, and the year of the survey. So, for example, if we're comparing telehealth use by race or income, regression will help us ensure that those differences aren't really due to just the group being older or concentrated in a particular region, but are actually focused on the outcome itself. After sort of fitting the model, we transform the results into these adjusted annual percentages. And here we sort of have 2 ways that we sort of thought about going about this. One way that we thought about doing this was using pooled adjusted adjusted odds ratios. And so what that means is we would combine the data across the survey years that we had, so from 2019 to 2024. We would then divide by the total number of years that we pool together so that the survey weights that we generate are representative of the midpoint of the survey period. So if we did 2019 to 2024 and combined all those populations together, we would have a population that's sort of representative of the US population around 2022. And so using that, we can calculate odds ratios, which is basically how much more at risk is a particular population for an outcome compared to another population. What we ultimately decided to do was to get year by year rates because we thought that would be more informative, especially given a lot of the pandemic era safety net policies that changed that would have meaningfully changed outcomes such as access and affordability. And so what we did was we would also calculate 95% confidence intervals using this technique called bootstrapping. So bootstrapping is a technique that involves repeatedly simulating new samples from a statistical model and recalculating our estimate each time. And so by figuring out how much those simulated sample estimates vary from each iteration, we can obtain a really reliable estimate of uncertainty around the percentage we report. And this is really important when we're looking at populations that are of smaller sample sizes. So populations like the American Indian Alaska Native population that historically has lower participation rates in the NHIS just because of a variety of factors, including a small population. We can obtain reliable estimates for that population as well. And so it's also really important that we use this approach to transform our model outputs into probabilities. And so I think one thing that I think what we really tried to do with these set of reports is really make sure that they're transparent and reproducible. So every estimate that we produce is weighted, it's adjusted, it's generated using the same framework, and all the code to reproduce these analyses are publicly available so that anyone online that's curious and reading these reports and is interested in learning how we're doing these analyses can download the code, download the data, and reproduce it themselves right in front of them on their computer, which I think is really important.
So I guess so you talked about sample size being a consideration for the stability of estimates. And I think one thing that when I read these reports, I think maybe for exercise or really any of these things, I'm curious maybe for people with self-reported history of ASCVD, because that's what's being measured, patients with self-reported history of ASCVD, then split them up into income strata and then ask what fraction of those individuals are meeting the exercise guidance or whatever. And I guess my question is, you guys look at all people and then the stratas of income or race and ethnicity, but not necessarily patients with ASCVD and then the income or race strata. And I just, was just going to ask you, like, why was that decision made? Was it a technical one? Was it a philosophical one?
Right, and that's a really good point that you raised, Adith. And so what you mentioned is exactly right. So we initially stratified the U.S. population by ASCVD status and looked at outcomes comparing outcomes between those that have ASCVD and those that don't have ASCVD. But for subsequent analyses, when we're stratifying by race and income, we stratified among the entire U.S. population rather than the subset of individuals with ASCVD. The reason that we did that is because ASCVD prevalence is about 10% from that's the estimate in the US population from the NHIS. And so among all adults, that would take our 30,000 sample size to about 3,000. And then when we further stratify by race and income levels, since we wanted to have the greatest amount of granularity for our income levels and as many race and ethnicity groups as we could include, when we did those subcategorizations, we found that some categories of race and ethnicity and income had fewer than 100, fewer than 200 individuals in that group. And so what happens when you reach those very small sample counts is that the stability of the estimates that you generate in the confidence intervals become very large by nature of a small sample size because there's so much variation. So we opted not to go that route just because we wanted to be sure that we would maintain a high level of granularity, but at the same time, we're reporting estimates that are stable and statistically stable and that confidence intervals aren't exceedingly large.
Yeah, that makes sense to me. And I think maybe my last question to you is, what do you think for you personally, and just sort of maybe using NHIS, maybe using other data sources, what are sort of important questions that you think you want to pursue, that you think others should consider looking at, that is sort of related to this theme?
Two projects are really animating my thinking right now, and I'll describe them both a little briefly because I think they're both really interesting. The first is this sort of question of, are there communities in the United States that have already solved some version of this health disparities problem? And I think when you look at national data, you see sort of persistent trends as, for example, in cardiovascular mortality disparities. We see Black adults that are dying at higher rates, people with lower incomes are dying or enduring a disproportionate burden of poor health outcomes. But I think that the national average is sort of obscure local variation. So I think somewhere in this country there should be some zip code, some county, some city where those gaps have sort of collapsed, where, for example, cardiovascular mortality rates between Black and white residents or low and high income residents are really equivalent. And if that place sort of exists, I really want to find it. And I think we can use some data source like the CDC Wonder dataset, which gives us county level mortality data, and we can really map where health equity in, for example, cardiovascular outcomes has been achieved. And sort of hopefully my aim would be if we can reverse engineer the community infrastructure, the policy environment, or whatever programs that made that possible. So like I mentioned before, I really think that community-based public health infrastructure is what's most valuable in enacting these changes. And I think the most scalable solutions and the ones that are worthy of emulation aren't going to come down from some national directive, but are actually maybe already present in our communities today. The second sort of project is centered about life expectancy. And life expectancy in the United States has really plateaued over the last decade. And the public dialogue around life expectancy and extending it has really been focused on raising the ceiling. So how do we get people that are living to 80 and 90? How do we get them to live to 100 and 110 and beyond? But I think what really gets far less attention is how do we raise the floor of life expectancy? And so there are a lot of Americans that are dying at 40, 50, and 60 before retirement age, before they've even had a chance to collect a single Social Security check, for example. And these early deaths are really anchoring and bringing down our national life expectancy as well. And so I think what I really want to understand is, well, who are these individuals? What are their risk factors? What are their behaviors, causes of death? And how can we help them live longer? And I think this might be answerable by linking the NHIS to to the National Death Index with mortality data, so we can track individuals forward in time and characterize premature mortality in this very nationally representative sample. So I think those are two projects that I'm really interested in. I think are my natural extensions of sort of this work in health equity that we've done with these 5 reports.
Yeah, those are 2 exciting avenues. And Rishi, thank you for being on today. It's great chatting.
Thanks, Adith.